That's exactly what I was saying. Matt, you can see the screen?
Yep, I can see. Thank you.
All right, sweet. So we're gonna talk about shoulder imaging, just basics, anatomy, cuff stuff, and some label stuff. And then, yeah, I don't have any cases, but there's some embedded here. So I'm a big Ultimate Frisbee fan slash player, and you can imagine with activities such as this, if you don't dive correctly, or even if you do, sometimes you can have shoulder injury, subluxation events, and I think that's pretty much how I messed mine up. So you're supposed to dive on your chest like this guy, not on your shoulder like this guy, that's usually how it happens. So yeah. So if you guys haven't played, I recommend it.
Just saw an ACL tear from one on
Yeah,
Wednesday.
yeah, I read that.
Did you read it?
Yeah.
Yeah.
And I'm doing a study now, that's my dog, where we're basically look at 11 years of Ultimate Frisbee injuries from our institution, so
Nice.
characterize them, get some radiology images, 2 cats, 1 dog, Browns fan. All right, so you gotta know the anatomy, right? If you don't know the anatomy, the pathology is difficult. So, you know, are you all tubercle or tuberosity people? That's the real question. I think tells a lot about somebody. I go back and forth between them, but I think more often I'm tuberosity.
What is that
Tuberosity.
supposed to then if you go back and forth?
I guess I
Can't commit?
Yeah.
Sometimes you're a Browns fan,
Yeah,
sometimes
well, that's mostly always a Browns fan, but tuberosity and tubercle is just interchangeable, I feel like. I did look it up, I think tuberosity is more for medium-sized insertions and tubercles for like smaller sized insertions, but. Okay, so this was initially for some people, but I'm assuming which one of these is not. Road screen enough, yeah. All right, so here's a nice little schematic. You know, we've got the 4 insertions. So we have the greater tube where 3 of them insert, and then the lesser tube where 1 of them inserts, which is the subscap. And you can see the subscap has this multi-pennate tendon architecture and the coracoid process. When we're looking at MRs, it's really important to, you know, look at the bony structures to kind of orient yourself if you don't have multi-planar imaging or, you know, in the moment. So coracoid process, if I'm seeing that, I'm seeing a tendon beneath it, it's the subscap. And then the supra is the most anterior of the greater tuberosity insertions, and then infra and then teres. And as far as tearing patterns, the supra is the most commonly torn of the greater tuberosity insertions, much greater than infra and much greater than teres minor. Teres minor, I think, I haven't been doing this that long, but I've only seen maybe 1 teres minor tear. Supra, and the articular surface is more common than bursal surface as far as. Unless obviously someone has external impingement or something like that, then you might have some bursal sided tearing. Subscap tears from cranial to caudal generally. We don't do really well on MR with subscap tears because varying degrees of patient external rotation. So if they're externally rotated like we want them, the subscap is nice and tight and we can see those tears a lot better, but sometimes they can't tolerate it because they have pain, so they may be internally rotated, and then the subscap is kind of just hanging loosely and it's more difficult to assess if there's a tear. So I usually try to overcall them. Here's just a little schematic of the bony insertion. So you have a more horizontal supraspinatus facet insertion. You've got a middle and posterior facet, so infra and teres. So the teres has more vertical insertion, whereas the obliquely oriented infra. And so sometimes I'm looking at the bony anatomy at the footprint when I'm reading these MRs to see which tendon I'm dealing with, because you know there's a lot of overlap with the supra and infra, which we'll get to. So the schematic is kind of showing the superior middle, inferior facets, lesser tube, long hip biceps in between them. And you can see here where some of the supraspinatus tendon inserts deep to some of the infraspinatus tendon. So I usually refer to this as like the common tendon, or when I'm dictating, if it's like the far posterior supra. And I think there might be some infra in there that I usually refer to it as that. And here is a dissection of that anatomy. You can see some overlap here between anterior infra and posterior supra. So this was a study done just about the cuff and looking at the vasculature of the cuff. And that basically, you've got a lot of vascularity coming from the enthesis and from the bone and then from the muscle. But the tendon, there's like this critical area where there's a relative paucity of vascularity. But that holds true for supra and infra. So I guess it's postulated. So like, in Achilles, we have the critical zone where it commonly tears, but in the rotator cuff, the vascular pattern doesn't really account for the distribution of tears, or else the supra and infra would tear at the same rate. So it's thought that there's like some intrinsic component due to the vasculature and some extrinsic reasons why there might be rotator cuff pathology. All right, so we're gonna do a lot of MR, but we'll do some X-rays here too, because oftentimes you're seeing the X-rays, not the MR, so we can glean some information from these. So here's our scapular Y view, and you can see the suprascapular fossa here, infrascapular region here for the infraspinatus, and then teres minor would be here. Again, coracoid processes are landmark for anterior, so subscap would be on the undersurface of this area and just beneath the coracoid process. And we would use this for dislocations too, right? You can see if it's abnormal on an AP, but technically speaking, you can't tell if it's anterior or posterior dislocation unless you have either an axillary or a scapular Y view. So knowing the coracoid's anterior and the acromion's posterior kind of also helps to orient yourself for dislocation events. AP, I'm looking at acromioclavicular pathology to see maybe if there's any external impingement, possibly. I can see if there's an ossicromial. The best view for that is the axillary view, in my opinion, to look for any accessory ossification sites. That's pretty much it. Sometimes I'm looking for intracapsular bodies in the superior subscapularis recess, which is usually generally in this area, where I'm looking for intracapsular bodies embedded within the long biceps tendon sheath, which is a common area for that to happen. Also, calcific tendonitis, looking for mineralization in the region of the cuff.
How long are you guys in?
Well, we got booted out downstairs. We were supposed to be in here till 9. You guys need it?
What time is your? Yeah, there's somebody here.
Yeah, we were supposed to have downstairs and somebody booted us out down there.
Okay.
So somebody needs it.
I don't know, I just knew somebody was already in here. There's supposed to be a meeting, I guess.
Yeah, let me talk and see. This is some reason. No, it's not your fault. It's something that it's definitely us.
Yeah, I mean, I can always do it like remotely, and everybody can just plug in computers. We don't really need a physical space, but it's nice to be here in person. Okay, so here's our basic, planes that we do on MR. So right, the shoulder girdle is not the same plane as the rest of the chest. So that's why we call them sagittal obliques and coronal obliques, because we oblique them to be parallel to and perpendicular to the actual glenohumeral joint. And so we can see sagittal should be nice cross sections of the rotator cuff tendons, and then the coronal oblique will lay them out nicely in their long axis. All right, so we'll just do some anatomy here. So usually I go from anterior to posterior. This is oh no,
I know.
it's dramatic. Let me play the videos on here. It's not going to be on the other.
I go to like 8.
Sure, yeah.
Hi, everyone.
Hello.
Great to see you. I hope it's my team.
Thank you.
You're welcome.
You want me to show you your machine?
I know, I'll go to the, thank you. I'll see you a little later.
I was shuffling this today. Videos not playing.
Yeah, suboptimal. Basically, a lot of it was just me going through the anatomy on that MR. Let's try one quick thing. We'll just open packs and see if there's an MRI that we can use in lieu of the embedded files, since we're all UH folks here.
Rohan, did you have your football game up tonight?
Yeah,
I just saw that in the news.
so I just found out too.
So where do you have to go?
So they're not having me go to like wherever the new place is right now, so I just my athletic trainer just told me, hey, stand by, and I was like, okay. There's been like a lot of just like fights, yeah, all this stuff. It's like even a month ago, the head coach was fighting. The school, like they stopped football practice for a few days.
Here's Solon sucks now at football, which is kind of tragic for me. It used to be good. So every year. It's probably because I graduated. Okay, so we're sharing screen. Let's get back to this. Retrieve. Okay, it's not the best looking cuff, unfortunately, but rather than keep looking, we're just gonna make this work, fortunately, given the circumstances. So I start far anterior. And I'm looking for my coracoid process. I'm gonna hang the coronal next to it just so. Okay, I'm gonna do. This go away, ideally, cross it. Okay, so coracoid process we see here, and just beneath that, we see our multipinnate tendon of the subscapularis. Then we start to see long head biceps coming up and over the intertubercular sulcus and hopefully inserting on or originating the supraglenoid tubercle. The next slice you really want to pay attention to. When we see our long head biceps, it's here. The next slice, and you can even see part of it in this slice, is the leading edge of the supraspinatus. And that's one of the more commonly missed cuff tears, is the leading edge of the supra. So you want to really scrutinize this area, make sure you're not missing any articular surface or any because the low grade articular surface tear, far anterior insertional supraspinatus, we call the rim rent tear, is the most common tear and also commonly missed. So we just want to make sure we don't do that. You can see this tendon is pretty ugly looking. It's a little thick. It's got increased signal intensity. And so this has definitely got some at least moderate tendinosis, I would say. And we can see that the footprint here is relatively empty. If we were to zoom here, you can see like this is the subchondral bone plate or the subinsertional bone plate here, this low signal intensity line. You don't see it as much here, but we see fluid where there should be tendon. So this is a probably high grade articular surface tear because I'm hallucinating that maybe this is one very thin fiber here remaining. It's probably for all purposes, intents purposes, full thickness with like one thready fiber remaining intact, which is preventing complete retraction of this whole situation. There's also an entity, the reason I saved this case is called the rotator cable. If you follow this structure here, it's like a little fibrous band of tissue that is there, and certain patients can prevent full, like complete retraction of a full thickness tear, and it will only retract to the rotator cable. So if you ever see a thickened structure like right here, it's the rotator cable. So if this was a normal enthesis, we would see that it would be a horizontally oriented, like about 10 to 12 millimeter low signal intensity line, and then here you can see it's more obliquely oriented. So then we're probably into the infraspinatus tendon rather than more horizontally oriented shelf like the supra would be. So it's normal. And then teres minor is all the way back here and inserting onto the posterior aspect of the greater tube. Labrum, you know, on the coronal plane, we're about scrutinizing the superior labrum, the inferior labrum, maybe a little bit of the anterior superior and anterior posterior labrum, but we usually use it in combination with the axials for labral pathology, for scrutinizing the anterior superior, anterior inferior, posterior superior, and posterior inferior labrum. You'll see in like older individuals generally, there's a lot of degenerative type circumferential labral tearing because this is not a normal labrum, and everybody who's a certain age gets labral tearing, both in the hip and the shoulder, so you know. Looks like the long head biceps tendon is here. There's some tenosynovitis. We can see fluid around the long head biceps tendon sheath. The other thing I'm doing, so here's the subscap. It's pretty decent amount of external rotation. There's some fluid in between these, just fibers, so maybe there's some low-grade intrasubstance tearing, but no retracted full thickness tears. The sagittal plane is best for long head biceps, so I'm finding this image where I see the glenoid And basically right around here, the posterior superior aspect, so let's say if we were like this, it would be the 10 o'clock position, 11 to 10. And you're gonna see a structure come off here, it's this, and see there's signal within it, which, so technically speaking, if it's intermediate signal intensity like this, like you see the difference between this and this, right? This is much more bright, and so it would, for a cuff tear, it's gotta be this signal intensity. You have to have fluid filling the gap, or like markedly abnormal morphology where you can tell that the fibers aren't making it. Otherwise, it's just tendinosis. So in mild, moderate, or severe tendinosis, it's just kind of a gestalt thing for me. There's nothing really that I use. The thicker it is, the more signal it has, it's severe. And then if it just has a little bit of signal, they think it's mild and moderate, somewhere in between. But so this is probably some moderate to severe-ish long head biceps tendinosis, increase in just of the signal, but not fluid signal intensity to suggest the split tear. And so that's where, and then you can follow the cuff tendons out on the sagittal plane till their insertion. And see, so like if I were to measure this tear, it would probably be maybe around this much, but sometimes I measure on the coronal plane. Because the sagittal plane, let's say you have an articular surface tear. If I'm all the way out here, the bursal sided fibers that are intact may be masking my articular surface tear, and I may not be able to measure the tear nicely, which is important for you guys and our orthopedic colleagues. So sometimes I'm doing it on the coronal plane, and I know my slice thickness is down here. You can always pay attention to that. Then you can just count how many slices you see the tear on and multiply it by this number. So let's say it's 1, 2, 3 or so. So then it's 10-ish millimeters. Okay, so what I'll do now, also the sagittal plane T1s, important for muscle atrophy, right? So muscle atrophy is a big prognostic indicator for cuff repair outcomes. And so we have our tangent line sign where you see, the base of your coracoid and your acromion. If you draw a line from here to here, your supraspinatus should fill that fossa. Also, I tell people, you don't want it to look like wagyu. You want a nice lean steak. So more wagyu, more fat, it's not good. So this one I'd probably pass on, muscle atrophy, at least related. It seems like the muscle bulk is all relatively similar. There's no like pronounced muscle atrophy in this particular case. And then I also look on the sagittal T1s for the AC joint and the acromial morphology. And I want to make sure that there's a nice fat plane beneath the clavicle and the acromion and the AC joint and my supraspinatus myotendinous junction. That's on. If I see mass effect here, altered morphology of the supraspinatus from impingement from these structures, then that's when I'm recommending or suggesting the possibility of external impingement. Other things you want to look for, here's your IGHL, your inferior glenohumeral humeral ligament, which in part inserts onto the anterior inferior labrum, and that's why those labral tears can cause a lot of instability. I think the IGHL is one of the more important passive stabilizers of the glenohumeral joint. And so, I'm scrutinizing the labrum anterior inferiorly, and then also for adhesive capsulitis, you want to look on the coronal fluid sensitive sequences, the ones that are fat suppressed like this, for any thickening or any pericapsular soft tissue edema of the IGHL that might suggest adhesive capsulitis. It's usually pretty obvious. I've got a lot of them saved. Also, nerves. We should talk about nerves. So there's the suprascapular nerve, and it's commonly impinged in 2 areas. One of them is, so here you see these dots here, that's our suprascapular nerve. And here's our suprascapular spinal glenoid notch and suprascapular notch. Suprascapular notch is right here. And then as we course more posteriorly and inferiorly, we start to see the spine of the scapula begin to come off here. This is our spinal glenoid notch. So that's where you want to be looking for paralabral cysts, and any patients who are having some weakness, you see big cystic things on MR coming out here. You want to look, here's the spinal glenoid notch here. Suprascapular notch, you don't really see super well on the sagittal plane. So look for paralabral cysts, and if you were looking for denervation, you'd be looking for just a mild, diffuse, bright signal on a T2 weighted sequence. So let's go back here, for example. You want to be looking at the muscle bulk, and it will be diffusely bright. And it's a different kind of brightness than a muscle strain. A muscle strain is described as feathery intramuscular edema. So you'll see bright signal like going between muscle fibers, and you'll see striations and stuff like that, where this is kind of like a more diffuse edema without striation. And that's what denervation, like subacute denervation would look like. And so if the suprascapular nerve is impinged at the suprascapular notch, you get supra and infra atrophy and edema or denervation. If it's at the spinal glenoid notch, the supra has already been innervated, so it's just infraspinatus. The other thing is your quadrilateral or quadrangular space, which is, you want to look at the T1s for these things because the fat planes are nicer. Is in this area, axillary nerve, which innervates deltoid and teres minor. So you want to be looking for most common cause of denervation due to axillary nerve pathology in this area is fibrous bands, which apparently we don't see that well on MR. So it's not usually that helpful, but we can still look for the teres minor and deltoid muscle issues. Okay, let's go back to here and see what we got to work with. Skip the videos. It's still sharing my thing, new share. Don't do it, don't you do it. Fast. Okay, case. All right, so here's the thing that's a common confounder or a pitfall for the long head biceps. Looks like there's two of them here, right? But one of these is the aponeurotic expansion of your supraspinatus. So your supraspinatus tendon, some patients is more prominent than others, can have this like thickened cord-like component that extends down along the long head biceps tendon and forms like part of the sheath, I guess. And so what you want to ensure is that when you're about to call a split tear, that you can't follow one of your supposed long head bicep tendons back all the way up to the supraspinatus. And I would love to show it to you, but I fear it's not going to be possible. But I can promise you that this thing came all the way back up and I could follow it distinctly from the supraspinatus tendon. And you won't see it going to the, so you can look at your sagittal plane, just make sure it's not originating from the supraglenoid tubercle, where your long head bicep tendon originates. Another thing is this, anybody know what this structure is right here? This is your MGHL, middle glenohumeral ligament, and will commonly be in this position just anterior to your anterior labrum. So you don't want to mistake fluid between your MGHL and your superior anterior inferior labrum as a labral tear. So just make sure that this is a distinct structure and separate from the labrum. Or if you're about to call a labral tear here, just kind of scrutinize that. Okay, findings, so that's fine. This is a video. It's just not gonna get lucky here. I think so. Okay, all right, so here's that aponeurotic expansion. You follow this thing up. This is your supraspinatus tendon. We're gonna follow that thing down. It's right here. Right here. Right there. And then it's distinct from the long biceps tendon. Here, similarly, we'll see. Got excited. First, let's do the thing. Think where you don't do it, right? That's it. Okay. All right, so which of the following is something is important to document for a reported rotatograph? So things we should always be doing is the AP dimension of the tear, because it has with
KRP valet. Reference KRP valet.
Degree of retraction, degree of atrophy, the tendon thickness that's involved, if partial. So we have low grade, moderate grade, or high grade. Generally, if the footprint is 12 millimeters, so 6 or more is high grade, and less than 6 is low grade. And if we're really not sure, we really think it's in between, we'll go with moderate grade. But and then we want to talk about if it's articular surface or bursal surface or interstitial tearing, because when you go on the scope, You know, if it's interstitial, you may look at the bursal surface, and you may look at the articular surface, you may not see the interstitial tear. So here's that footprint I was kind of alluding to, and you can see it's full here with nice tendon insertion. So normal cuff footprint is 10 to 12 millimeters, and then this is kind of how I suggested we grade. Less than 3 is grade 1, grade 2 is 3 to 6, and then grade 3 is more than 50%. Indications for surgery, there's much more than this, but you know, ortho bullets is the easiest reference to use, and this is just some things I gleaned from there. So this is how it would look on a sagittal plane and on a coronal plane. So coronal plane, remember, we're seeing muscle and tendon, and then on the sagittal plane, we're just seeing tendon. So this white box is tendon as you're cross-cutting it and cross-section, and it's inserted into the greater tube. So normal should be nice, homogeneously. It's going to be dark, so we probably should flip these colors, but nice and homogeneous. Partial thickness bursal sided tear would look like this. A full thickness tear, so some places may describe these different, but full thickness partial width means that there is a full thickness tear, including the articular surface, the interstitial, and the bursal surface, but it's not the entire width of the tendon insertion. So that's our full thickness partial width, and then full thickness full width. I try not to use this because I think some of the clinicians don't like this type of terminology, so I just do full thickness involving the entirety of the, if I think it's full thickness full width, or if I think it's full thickness partial, I'll just say full thickness tear involving the anterior 1 centimeter of the supraspinatus insertion. So this is like a low grade or moderate grade articular surface of the far anterior insertional supra. This is our rim rent, so you can see a little bit of fluid signal intensity undermining the bursal sided fibers. Here's our footprint, and there's just some fluid signal intensity far anterior here. So this would be a low grade articular surface tear, far anterior insertional. And then if I were to measure it, I'd say it measures from here to here, probably or 6 millimeters superimposed upon mild tendinosis. This is our sentinel cyst sign. So if you ever see a cyst extending into the infraspinatus, that's basically diagnostic for a tear somewhere. That's allowing for fluid to insinuate along that myotendinous junction. So look for that as a secondary sign. You can see here's that cyst, and I think there's some video images that will show that there was some component of tearing at the footprint that I'm too afraid to utilize. Here's full thickness tear, and you can see so chronic full thickness tears. You have high riding humeral head because of the loss of the thickness of the tendon here, and hypermobility presumably. And then you can get scalloping of the undersurface of the acromion. And then you also lose the normal morphology of the footprint. Like this is very round, there's no shelf here anymore. If we go back to one of the other cases, there was a shelf there. And there's no shelf in these chronic full thickness tears because this thing has been rubbing against the acromion for so long that they're both remodeled. You see advanced glenohumeral arthritis, so you can see the tendon of the supra is retracted here to the level of the glenohumeral joint. And here's some fluid, now in your volcano sign, basically where there's fluid that gets into the acromioclavicular joint and then can, rupture into the soft tissues. It's just the ganglion, here it is, ruptured. You can see infra is still intact here, at least at this slice. Muscle atrophy. So one thing to keep in mind is when you have a full thickness tear on the sagittal plane, so those full thickness tears are retracted. So the amount of muscle that you're catching on the sagittal plane and the normal depth that we go may be less, and you may overestimate atrophy, if that makes sense, because the muscle is retracted immediately out of the field of view. So you're only seeing the muscle that's like remaining in this particular slice. So the point is, when there's a full thickness tear and you're grading muscle atrophy, look at the axials and look at the coronals, because you'll see more of the muscle in that field of view to assess atrophy and just confirm what you think is happening on the sagittal plane. But we can see, Wagyu, this is like American, this is Japanese Wagyu probably. But this is nice, lean, grass-fed. Boutelier classification, so this is just how we would qualitatively and then give a quantitative score, I guess, but so less fat than muscle, same amount of fat and muscle, and then more fat than muscle. Here's that tangent line sign that I kind of told you about earlier. And we can see this muscle is not feeling that tangent line. External impingement, here's a nice case of acromioclavicular osteophytes here inferiorly. You can see on the MR that they're causing mass effect on the traversing supraspinatus myotendinous junction, which can be a source of pain. Here's on the sagittal plane, we have obliteration of that underlying fat. So this is why muscle atrophy is important, basically, correlated with extended tendon tear and is associated with tear recurrence after surgical repair, so it's important to comment for us. All of the following are something away. There it is. Oh, okay. Variants of the glenoid. So we've talked about the labrum now. So there's the Buford complex, there's sublabral sulcus or recess, and there's sublabral foramens. And so for at least trainees in radiology, some of the more difficult challenges are ascertaining whether it's a tear or variant. And so in 6 minutes, I will try to make you more comfortable with that. When viewed in FOSS, the glenoid most resembles which fruit? It is a pear. And here's a pair. Here's the glenohumeral ligaments on the sagittal plane. So anterior posterior bands of IGHL, you have your MGHL, you have your SGHL. You're not always going to see them so nicely. It depends on if it's an arthrogram, not an arthrogram, things like that. Okay, click on the MGHL. So that's this thing here. So this is a Buford complex. Hopefully, you can see here's our posterior labrum. The anterosuperior labrum is absent. And we have a relatively thickened and cord-like middle glenohumeral ligament. That's normal, Buford complex. And when you get, so all the labral variants in the glenoid occur from like 11 o'clock to 3 o'clock. So from the posterior superior labrum to like at the midline glenoid, basically. And if it goes away at the midline, then it's probably a variant. In this case, you can see the glenoid labrum reconstitutes antero-inferiorly a little bit inferiorly. So big Buford, not sure if anybody's had that from rallies, but it's a thing. I'm just too afraid to click on this, so we'll just keep going. This is a sublabral foramen. Okay, so the keys, part of the keys to differentiating tear versus variant is the morphology of the fluid signal intensity. One, see how smoothly marginated this is? There's no ratty, irregular like labral surface, and it's going nicely away from the labrum and contouring to the glenoid rather than in. Anything that goes into the labrum is tear. Anything that goes through the base of the labrum can be variant or conjugal junction tearing. Just depends on the morphology and the location. Here's our MGHL, just to differentiate that from the structure. This is variant, sublabral foramen. So if we're looking at this as a clock face, and we're going to call anterior as to the left. So from here, basically, you can have some variations from where your locking biceps tendon originates to here. Anything from here to here is always tear. But if you have some fluid signal intensity undermining the base of the labrum that's smoothly marginated either just at the 12 o'clock position or extending from 12 to 3, assuming that this is facing the correct direction, it can be variant, just depends on morphology. So smoothly marginated 12 o'clock, I would have called this a sublabral recess or sulcus. Not super ratty looking and looks pretty good. This is, I think, just a CT of a patient who's dislocated. So we can see here that the sagittal plane is really good for evaluation of the amount of bony Bankart. So we can see our pear is no longer really peary anymore. It's like kind of flattened at the anterior surface. And it's important to keep in mind what signal intensity bone is. So this is kind of what signal intensity bone is. So then we can deduce that this thing right here is also bone because it looks relatively similar. And this is our bony Bankart, and you can measure it from here to here, from here to here, to get an idea of how much bone loss you have of the anterior glenoid. You can kind of see here as well, there's some bone marrow edema associated with that. And like here's the bony Bankart fracture fragment. Like that. Scared. So here's the things. This is how we refer geographically, anatomically to portions of the glenoid labrum, superior, anterior, superior, anterior, inferior, inferior, posterior, inferior, and posterior superior. And the hip doesn't have an inferior labrum, so we just do anterior superior from like here to here, anterior inferior from like here to here, posterior superior from here to here, and posterior inferior from here to here. There's only 4 zones that we discussed in the hip. Rad source, by the way, is really good thing to use for radiology of MSK. lot less esoteric knowledge and very succinct and to the point. Here, okay, this is the key slide we can get close to ending on. So these are the ways we can describe or kind of differentiate labral tears versus variants. So within the labrum, as opposed to undermining, is most likely to be pathologic. Irregular margins is more likely to be pathologic. Signal intensity posterior to the long head bicep tendon origin, so that's at like 10 or 11 o'clock position, is more likely to be pathologic. Below the 3 o'clock, we already talked about that. And then if that fluid space is 2 millimeters, greater than 2 millimeters, or 2.5, if it's an arthrogram, it's more likely to be pathologic, and the presence of a paralabral cyst is basically pathognomonic for tear. So here's a paralabral cyst in this spinal glenoid notch. Not really any muscle edema here that I can differentiate. But here we can see the infraspinatus is a little bit oedematous. And maybe there's a paralabral cyst I'm not seeing here, at least not including on this image. You can see maybe a little bit of atrophy associated with that edema relative to the supra and the subscap. This is a ALPSA, anterior labral periosteal sleeve avulsion. So we have all these named types of labral tears. One is this, so you can see the labrum is all bunched up and it's medialized. That's the key, and it's attached to the periosteum, but it's stripped from its normal location. So this is more indicative of a chronic labral tear. Here's our Hill Sachs. We can see a bony deformity of the posterior humeral head. That was the ALPSA. Here's another one. This is a Perthes. We can see, in contrast to the ALPSA, the periosteum is elevated. You can see the periosteum here, but there's no medialization of the labrum. It's still in its relatively normal location, just lifted. It's not like here, which would be more indicative of an ALPSA, and this is less likely to be chronic. So just to differentiate ALPSA for Perthes. Okay. Well, we gave it our best shot, guys.
Thanks for squeezing it in. That's so super helpful.
Thank you. So, all right. Have you guys rotated in MSK? Are you rotating? Are they rotating?
I spent 2 days.
Nice.
And then next.
Cool. Well, hopefully I'll be up there.